Hello, guys, and welcome back to Counter 10. My name is Ani, and on today's episode, we're doing another practice live Viva demonstration. Today, our guest candidate is Robbie, who I have to thank in advance for volunteering to do this, and coming back to be a guest examiner is Derek, now being on the other side of this exam. I hope that Viva preparation for everyone is going really well, and Robbie absolutely smashes the Vivas today, and it's a real reflection of the work that he's put in, and I'm sure the work that you guys are all putting in preparing for the Viva. The structure for the Viva today is same as last time, 1 minute perusal, and then 4 topics given over 20 minutes. We finish with both some non-technical and technical feedback, and I hope you guys get a lot out of this. So thanks again for Robbie and Derek for joining me for this episode today. And with that said, let's dive straight into it.
1, 2, 3, 4.
Hey guys, and thanks for joining me for another Practice Live Viva demonstration. I really appreciate you guys joining me. I know that the listeners really love these episodes, especially when it's Viva time and Viva season. So thank you very much, Robbie, for volunteering, and thank you, Derek, for coming on and being on the other side and being a guest examiner.
No, thanks so much for having us, Arnie.
Before we get started, Derek, how does it feel to be on the other side comparatively to last sitting when you were getting grilled and being a guest candidate?
Yeah, look, definitely a lot nicer. But I actually worked with Robbie, so I've had the pleasure of vibing him a few times, and he's done very, very well. So looking forward to see how he goes this time round. But yeah, appreciate having the opportunity to do it last time. It was very helpful. So very happy to return the favor.
Oh, that's awesome. And to put you on the spot, if you could think about one thing that you learned from the actual day when you're doing the Vivas that no one really prepared you for, or that you thought was a bit different, and you're like, oh, I wish I knew this in retrospect. Could you think of one tip that you want to give Robbie and the people listening?
Yeah, I think in general preparing for the Viva was just kind of like a bit of a numbers game. And fortunately by the day, I think there were only 2 out of the 12 that seemed unfamiliar. Um, but I think they do tend to push you to a point where you don't really know the answer, or it gets you in unfamiliar territory. Um, and so I think you kind of just go back to first principles, and that seemed to work. Um, but yeah, I guess the other thing was that I feel like when you're practicing Vivas with people, they'll often say, like, if you're kind of 50-50 about something and then you say the wrong thing, they'll say, like, oh, are you sure? I felt like that didn't really happen on the day. And so they'll kind of just say,
Mm.
okay, and you kind of just kind of need to move on.
Nice. I think that second point there is you forget that in the moment. Like I know I remember doing lots of practice Vivas, and even though when I do practice Vivas here, I would say, "Are you sure?" And examiners there, like I've said multiple times, they know where you need to go to get marks. And we're doing this without a marking sheet, and we're just trying to rattle off some questions, and you answer them the best you can. Robbie, this is uncharted territory for lots of candidates sitting this setting because you've got
Mm.
the biggest break between written and the actual Vivas. So, and I've had a lot of people come up and being like, "Hey, can you give me a Viva?" And I've said, "No, just take your time. You're 6 weeks out. We're 5 weeks out now. How's it been trying to pace yourself to make sure you don't get burned out before we jump into the Viva today?"
I think it's actually been quite tough, to be honest. I think all of us had that impetus and drive to kind of launch right into it after the written. So I think most of us had about a week off. But then I guess you're trying to study and grind for about 11 more weeks, which is, I think, too long realistically. And I think the fatigue and burnout's been felt among I know myself and most of, I think, my colleagues as well. And I think that's where, taking a step back and recognizing that you just need a break, take some time, pace yourself, and then I guess trust the process really helps out there. But yeah, it has been pretty drawn out and pretty long.
I think with that long break, you can even afford to give yourself an extra week break in between. And by now, people should be kind of ramping up and then maybe having a couple of days off, before the 3 week mark. So we're 5 weeks out now. We're going to launch into this live practice Viva demonstration. We've done a lot of these now. So I think, Robbie, you know the drill. Derek, you know the drill. It's going to be a 20-minute Viva. Derek's going to start off with an opening stem, give you 1 minute to think about it. On the day, you'll have 2 minutes to think about it, but today we'll just do 1 minute as a perusal time. He'll give you two topics that'll go for 10 minutes total, and then I'll take over and give you two topics that go for 10 minutes total. So it'll be like having one whole Viva station. Any questions about that format?
That sounds great.
Awesome. Well, whenever Derek's ready, we've both got timers on, and we'll start our timers whenever Derek says so, and you'll get your opening Viva question in a little second.
Alrighty, so we'll start the timer now. And your opening stem is list the physical properties of desflurane. All right, Robbie, have you heard and understood the question?
Yep.
Can you tell me the physical properties of desflurane?
So desflurane is a halogenated hydrocarbon. It has a boiling point of about 23.5 degrees Celsius, a saturated vapor pressure of 669 millimeters of mercury, a blood gas partition coefficient of 0.45 or 0.42, a muscle blood partition coefficient of about 2, and a fat blood partition coefficient of about 29, sorry.
And what about the MAC?
MAC of 6.
Great. And
Six,
what about
yeah.
molecular weight?
Not entirely sure. I think it'd be about 170
Yeah, that's it.
Daltons.
Yeah, perfect. So we're going to talk through each of those values. So you mentioned that it's a halogenated ether. What's the significance of it being halogenated?
I guess addition of halogenated groups increases potency of a inhaled volatile anesthetic. It also alters the metabolic profile and how it is metabolized in the body as well.
Okay, and do you know which halogens are included in desflurane?
So it's a polyfluorinated hydrocarbon, effectively. So primarily fluorine.
Yeah. And what's the significance of the carbon fluoride bond?
So the carbon fluoride bond is very stable and less prone to being metabolized compared to, say, a carbon bromine or a carbon chloride bond. And this is largely owing to desflurane's very low metabolic rate of about 0.02%.
Great. And so the molecular weight of 168, is that high or low?
Compared to other volatiles.
Yeah.
I guess it's slightly lower than other volatiles, but I'm not entirely sure.
Yeah. And do you know what the significance of that is, having a low molecular weight?
I'm not entirely sure, no.
That's all right. So what is a boiling point? Sorry, I think Robbie's.
Oh,
We're back.
I don't know. So I think I just cut out for a moment. Yeah,
You're
we're
right.
back. What a boiling point is the point at which saturated vapor pressure equals atmospheric pressure.
Great. And tell me about the boiling point of desflurane. Is that low? Is that high?
We've got a very low boiling point of 23.5 degrees Celsius, which means it can be prone to undergoing boiling at room temperature in most theaters potentially.
And what is the saturated vapor pressure?
669 millimeters of mercury.
Is that low or high compared to, say, sevoflurane?
That's much higher than all other vaporizers, volatile, sorry, which means it needs its own vaporizer to be appropriate for use.
Okay. And what is the relationship between temperature and saturated vapor pressure?
So it's a non-linear relationship, such that saturated vapor pressure increases as temperature increases. It tends to be a slightly exponential curve.
Yeah, you mentioned that we can't use a standard vaporizer. So why is that?
So this is two main reasons. So the first is desflurane's boiling point of 23.5 degrees Celsius. And it means that at normal room temperature, theater temperature, it can intermittently undergo boiling, which will lead to very inconsistent delivered concentration. The other would be its very high saturated vapor pressure of 669 millimeters of mercury. With a normal platinum vaporizer, we would need a very high, extremely high fresh gas flow rate in order to accurately dilute the desflurane to a concentration of 6%.
And what vaporizer do we use?
Take 6.
And how does that work?
So it's a measured flow vaporizer. So effectively, it boils the desflurane at 39 degrees Celsius and then injects a pressurized stream of this desflurane. There is a pressure transducer that measures the incoming fresh gas flow and fine-tunes the output concentration based on the fresh gas flow rate. And we also set a dialed concentration.
Great. We're going to talk about the blood gas partition coefficient now. So do you have a definition for that?
Yep. So the blood gas partition coefficient is the ratio of the concentration or partial pressure of a volatile in alveolar gas to blood when it is at the equilibrium between the two states.
And is desflurane's blood gas partition coefficient, is that low or high compared to other?
It's very low. Really, the lowest that we have apart from xenon.
And what's the significance of that?
It means that desflurane has very rapid onset and offset, owing to its low blood pressure, but low blood gas partition coefficient. It means that we rapidly achieve equilibrium between the alveolus and the blood.
Great. We're going to move on to a different topic now. So what is phenylephrine?
Phenylephrine is a synthetic non-catecholamine that is used for blood pressure control and management. It is a direct-acting alpha-1 agonist.
Are there any other uses for it?
Yes, it can also be used potentially to prevent congestion, for example, nasal congestion, as pseudoephedrine, which is, I guess, an isomer of ephedrine.
Are there any particular anesthetic cases that would use it for?
So generally, seems to have preference for cases where we know that we'll need some kind of blood pressure control, primarily increasing SVR. So that would be things like when you use a neuraxial, such as with a Caesar, and potentially any case with an elderly individual where you expect a reduction in SVR and venotone.
Okay. So what's the overall effect on blood pressure?
So via acting on alpha-1 receptors, which are GQG protein coupled receptors, acts to cause vasoconstriction and venoconstriction. The vasoconstriction causes an increase in FVR, which increases MAP, and the increase in venotone increases venous return preload and also increases MAP. So overall effect is to increase systolic pressure and MAP.
And what about diastolic pressure?
Diastolic pressure could potentially increase slightly as well, though it should be largely unchanged.
And so what's the overall effect on cardiac output then?
So I guess it depends on the patient's state and status, but generally we'll have an increase in afterload, which will slightly decrease cardiac output. This will be counterbalanced by an increase in venotone and preload, which would increase cardiac output. I think in an average healthy individual can slightly decrease cardiac output.
And what about the effect on heart rate?
There is a reflex bradycardia that occurs via the baroreceptor reflex when there is an increase in SVR.
And what effect would that have on cardiac output?
Would also reduce cardiac output.
Okay. Is the effect on the arteries or the veins more significant?
I believe it's more of a significant effect on the arteries rather than the veins.
Okay. What's the effect on coronary artery supply?
So I guess it's a counterbalance of the alpha-1 direct vasoconstriction that would reduce coronary vascular radius and thereby increase resistance, decreasing blood flow. However, there is an increase in MAP and potentially aortic root pressure, which would favor an increase in coronary blood flow. I think, again, depends on the patient's premorbid state, but overall, likely a small decrease in coronary vascular supply.
And what about for the demand for oxygen?
Overall, would increase demand for oxygen. This is one, due to increase in afterload, which will resultantly increase wall tension and wall stress. And secondly, increase in preload as well. The decrease in heart rate, the reflex bradycardia would slightly decrease oxygen demand, but I think this would be outweighed by the increase in afterload and mild increase in preload.
And what would the other effect be for the decrease in heart rate on coronary blood supply?
But increased diastolic filling, which would increase percentage of diastole and blood flow, particularly to the left heart.
Great. Why is that different between the left and the right heart?
So there is phasic nature of blood flow. Effectively, coronary blood flow acts as a Starling resistor mechanism, where the limiting pressure tends to be intraventricular pressure. The left ventricle is exposed to much higher pressures throughout systole than the right ventricle, such that ultimately intraventricular pressure can exceed aortic root pressure, thereby limiting blood flow, substantially during systole, whereas the right heart is more sustained.
So you accidentally give an overdose of 10 times the normal dose of phenylephrine. What would the effect be?
So the effect would be a marked increase in SVR, blood pressure, and afterload. This would potentially cause acute left heart failure, leading to potentially pulmonary edema and right heart failure as a result. You may also have hemorrhagic infarcts and events intracranially and also elsewhere in the body.
Would you treat it?
Yes, I think you would treat it. Yeah.
Yeah. What's the half-life of phenylephrine?
The half-life of phenylephrine is about 1 hour.
Okay. So what would you treat it with?
So I guess the best option would be an alpha-1 blocker, such as phentolamine or phenoxybenzamine. Other options would be other mechanisms aimed at reducing blood pressure. So you could use potentially calcium channel blockers, beta blockers, ideally something that can be administered intravenously and have a very rapid onset of
Yeah.
blood pressure reduction.
So what if you gave a beta blocker? Do you have yeah, it may cause a decrease in your heart rate.
Mm.
Would that be something that you'd be concerned about?
So I guess it would reduce myocardial oxygen demand, but this could potentially worsen and precipitate the left heart failure, particularly in acute heart failure. Beta blockers can precipitate this. However, you could potentially use maybe a non-selective, although this would lead to a further increase unopposed alpha-1 tone.
All right, thanks, Robbie. We're going to move on to a different topic.
All right, Robbie, can you tell me what is the hemostatic response to injury to a blood vessel?
So hemostasis is the cessation of bleeding at the site of injury while maintaining blood flow elsewhere in the body. The hemostatic response tends to involve primary and secondary hemostasis.
Is there anything that happens before primary hemostasis?
Vasoconstriction.
And how does that occur locally?
So it occurs locally via reflex effect in the arteries, but in the arterioles rather, but also via release of vasoconstrictive mediators such as thromboxane A2 and serotonin.
Where are those mediators released from?
The endothelium, but also platelets.
Okay, is there any other mediators that are released by the endothelium?
Endothelin as well would be released.
Yeah, good. How do platelets first become activated?
So the initial activation occurs via adhesion. So the GP1A receptors integrins on platelets bind collagen directly, and the GP1B integrins bind von Willebrand's factor, which is bound to expose collagen. This leads to a conformational change and activation of the platelets. Platelets then release their granules, and this leads to a further positive reinforcement activation loop.
Yeah, good. Where else is von Willebrand factor found?
So it's found in platelets, also found from the endothelium, and I believe it's actually synthesized by endothelial cells in the liver. It's not hepatocytes, but endothelial cells in the liver.
Okay, is there some circulating in the plasma?
There is, yes.
Okay, good. So is von Willebrand factor only needed for adhesion, or is it needed in other processes of platelet activation and aggregation?
It's also required in the aggregation phase, whereby it binds to the activated GP2B3A receptors, leading to cross-linking of the platelet plug.
Okay, is there any other things that bind to the GP2B3A receptors?
Other thing would be fibrin and fibrin cross-linking.
Okay, all right. Say I had someone that was deficient in von Willebrand factor. How would I be able to tell that?
So I guess this would be based on clinical findings and investigation findings. So clinical findings would be a history of bleeding diaphyses, potentially throughout the patient's life. And then you can have qualitative and quantitative investigations. So looking at the bleeding time, looking at von Willebrand factor antigens, and there are some provoked tests that you can do as well.
Okay, so before we move on to von Willebrand factor antigens, say on a normal coagulation panel, what would I expect to see different in someone with von Willebrand disease?
So largely, most coagulation factors should be maintained. The one that can be decreased is factor 8, because von Willebrand factor acts as a carrier for factor 8. So this could potentially lead to a prolonged intrinsic coagulation time.
And how does that reflect on your, say, coagulation studies?
So it could be slightly prolonged APTT.
Okay, good. And you mentioned there's some specific tests. So what does the von Willebrand factor antigen measure?
So I believe it measures antigens that are present to von Willebrand factor. I'm not sure exactly which ones, but I know depending on the type of von Willebrand disease, whether it's type 1 to 3, there is potential expression of these.
Okay. You said factor 8 is linked with von Willebrand factor. Where does factor 8 play a role in the coagulation cascade?
So it forms the intrinsic 10A complex by binding activated factor 9 and calcium. And this then leads to the activation of 10 to 10A.
Okay, what factor activates factor 8?
Factor 8 is activated by thrombin, so 2A.
Okay, and what else does thrombin activate?
Thrombin also activates 5 to 5A
Hmm.
and I believe 11 to 11A
Okay, is there any
and
other
13.
thing? And 13. What is 13?
Factor 13 results in the cross-linking of fibrin at, after the formation of this fibrin mesh binding to platelets.
Okay, so once this fibrin is made, how is the fibrin broken down in our body?
So the fibrin is broken down by fibrinolytic pathways. So predominantly plasmin binds fibrin via its lysine binding sites. It then complexes with an activator such as plasminogen activator, and this converts it to plasmin. And this plasmin then degrades fibrin into soluble monomers.
Do you know any drugs that act on plasmin?
Yep. So we have TXA, and there's another one, a proteinin, I believe, and there's an epsilon agent, whose name I forget.
And what's the mechanism of action of TXA?
So TXA is a lysine analog. It binds to lysine binding sites on plasmin, preventing its binding with
Okay,
fibrin
I'm going
and
to stop there
PPA.
and go to another topic. How might you give lignocaine in the perioperative period to a patient?
There are numerous routes of administration for lignocaine. It could be delivered topically, such as if EMLA. It can be delivered subcutaneously, for example, with an IVC insertion, perineurally with ultrasound for a nerve block. It can be delivered neuraxially, particularly with epidural, and it could also be administered IV.
Okay, what's the maximum dose of lignocaine that you're aware of?
So lignocaine alone is about 4 milligrams per kilogram. With adrenaline, it's about 7 milligrams per kilogram.
And why does the dose increase with adrenaline compared to without adrenaline?
Adrenaline leads to vasoconstriction of the surrounding vasculature, leading to reduced systemic uptake and an increased effective dose.
And why do we care so much about reduced systemic uptake?
Because it's the peak plasma concentration of local anesthetic that determines systemic toxicity.
Yeah.
So by reducing systemic uptake, we reduce this.
Good. Do you know what the maximum dose for airway topicalization is with the lignocaine?
I believe it's 9 milligrams per kilogram.
So why is that dose higher than the dose with adrenaline?
I'd suppose it'd be reduced vascular uptake in general from the airway mucosa, but I'm not entirely sure.
So do you think that the airway mucosa are a vascular rich tissue or a vascularly poor tissue?
I think they're vascular rich tissues, what I would have said, which would lead to an increased uptake. But with the max dose, it seems like it would be potentially a more vascular poor tissue, or there'd be increased first pass metabolism of lignocaine absorbed by this route.
Is there anywhere else that lignocaine that's been administered on the airway could go down, which is not a fast absorbing tissue?
I suppose it could go to more cartilaginous tissues, which are not really, which are very poorly vascularized.
What if I told you some of it will go down into the stomach? What do you think the absorption or the bioavailability of lignocaine would be through that route?
So it'd be very poor, which is owing to its very high first pass metabolism.
Yeah.
And I believe it'd also be very ionized in the stomach environment, which would lead to decreased absorption.
Yeah, good. So if you say that the airway topicalization dose of lignocaine is 9 milligrams per kilogram, and I were to tell you in pediatrics it's 5 milligrams per kilogram, why is the pediatric dose lower?
I'd assume that there's less absorption by the stomach, and most of it would stay potentially in the airways, leading to increased absorption.
Yeah, is there any other physiological reasons why there might be a difference between an adult population and a pediatric population?
So pediatric populations might be, depending on the age, at increased risk of local anesthetic toxicity, primarily due to decreased metabolism,
Yeah,
hepatic
good.
metabolism.
In what other age groups would you want to decrease your maximum dose of lignocaine?
Pregnant individuals, they have increased sensitivity and decreased alpha-1 acid glycoprotein.
Mhm.
Elderly individuals due to reduced hepatic clearance, and I guess patients with severe hepatic failure as
Yeah,
well.
good. At what plasma levels do you start to get systemic toxicity with lignocaine?
Greater than 5 micrograms per mil.
Okay, and how does this present with local anesthetic systemic toxicity?
So there are CNS and CVS symptoms. The CNS symptoms are biphasic. You have initial excitatory symptoms with perioral numbness, tingling, and tinnitus preceding. This is then followed by agitation, distress, and potentially seizures. Then there are the inhibitory effects. So this would be apnea, coma, potentially death. This is then followed by the CVS symptoms, which are also biphasic. So initially you have increased heart rate and blood pressure. This is then followed by myocardial depression, which leads to decreased blood pressure, direct vasodilation, which leads to further decreased SVR, and arrhythmias such as bradycardia, conduction block, VTVF,
Sure.
and asystole.
At what plasma levels do we expect to see CVS symptoms?
Greater than 25 micrograms per mil.
Okay. So you said sometimes we can use lidocaine IV. So say I take a 70 kilo patient and I give him a 1 milligram per kilogram IV bolus of lidocaine. What would be the immediate plasma concentration, roughly?
So it depends on how fast you inject it. But I guess you said, is it 1 mil?
Yeah, 1 milligram per kilogram. So say I gave 70 milligrams.
Yep. Okay. So if you give 70 milligrams, I guess a 70 kilogram individual has about 5 liters of circulating blood volume.
Sure.
If you give this over maybe a quarter of a minute, it'd be 70 divided by about one. So it'd be about 70 micrograms per mil.
Yeah, let's say for the math's sake, it's around about 10 to 15 mics per mil. How
Mm.
can I give that dose, but the patient doesn't end up having any of those systemic toxicity effects?
So lignocaine, some of the lignocaine will be bound to protein. So it's about 70% protein bound. There is also some of the lignocaine will be diluted in the blood as it passes through mixing chambers such as the heart into pulmonary vasculature. Some of the lignocaine will actually be taken up by certain tissues such as the lungs.
Perfect.
Um,
We'll stop there. You take a break. Take a break. Gather yourself. While
well,
I'm sure Derek and I will just be sitting here being like, whoa,
Yeah, absolutely. That was awesome.
that was really high quality. Um, I was trying not to show it in my face as Derek was grilling you on topics that I had forgotten about completely.
yeah,
But
Derek's questions are pretty tough, man. That was
Yeah, sorry, dude.
geez,
I had to make them hard for you. You know how good you
that's
are.
good.
yeah.
That's good.
I know it's really hard, but I always ask people to think about how they went immediately after. How do you think you went in the moment going through that?
I think I should have done better on the phenylephrine one. I think that one I was surprised by some of the uncertainty I had with the answers I was giving. But I guess overall pace was good. Getting through the questions was good. And yeah, I feel like I could have maybe done a bit better, but overall not super disappointed with the performance.
Well, I would hate to see how you think you could have done better with that performance. Not trying to blow smoke up you, but that was really high quality. And I think we'll go and maybe Derek can give some feedback first, given that he gave the first fivers. But I might just say some non-technical feedback just before Derek starts on just one thing I noted, which maybe Derek saw when I was vibing you, but the word I wrote down in my notes here was efficient use of words. You were saying some really high level answers and some really high level concepts with minimum time to the point where I was thinking in my vivas, I had made around about 16 questions for each of these vivas. And I got to roughly around about the end of them. And I thought to myself, if anyone gets to these 16 questions, I'm going to have to start thinking about random stuff I'm going to ask. And so your efficient use of words, but it wasn't just efficient use of words, it was efficient, accurate use of words, which I thought was really good from a non-technical perspective. That really seemed like you were flying through that Viva to the point where I wasn't even paying attention to some of your answers. I just thought what you're saying is probably right. But I'll let Derek give you some feedback on how he thought you went on his two topics.
Yeah, no, I agree. I thought you were really concise with your answers. You definitely didn't waffle. And someone described like vibing in general was like it's not like the SAQ where you kind of get asked a question and then kind of put down everything you know. You kind of just treat it as a bit of like more of like a tennis rally. So you kind of just want to be going back and forth, which is what I think you did. So I think for like the questions that you can just answer really quickly, you did that, and then we can move on, and then you can get just through more of the content and get more marks. Um, but yeah, generally, I thought you did really well. I thought you were really clear with all your answers. But I guess moving through the two Vivas, so these were two that I got on the day. The desflurane one was an opening stem one. You got all the physical properties there. At the end of it, they did give you a piece of paper with all the values on there. So if you didn't know any of them, then we could just go through and talk about it. They didn't really ask about the muscle blood or fat blood, but it's good that you knew those. Um, I kind of went a little bit harsh and talked about like the structure activity relationship, or at least talking about like halogens and the structure of
Mm,
volatiles, which I didn't actually get, but I thought you did really well on. The significance of the halogens is I've got here that it just makes it less flammable. And you're right
mm,
in that the carbon fluoride bonds are really strong, so less resistance to metabolism, and that's why desflurane's metabolism is so low. Um, Went on to talk about the relationship between the boiling point and or temperature and the saturated vapor pressure. And I think that's the key point is that it's a nonlinear relationship. And so, minor changes in temperature, if it's close to the boiling point, means dramatic swings, and that you need really high flows to deliver the um, low percentages that you need
mm.
to get to that Mac. You got through most of it. I think because I talked a bit about the structure and stuff, we didn't get to the last bit, which was just talking about the environmental effects of desflurane. And they also asked what are some ways that we can minimize this. So I guess talking about low flow anesthesia and using max sparing agents. Did you have any questions about that one, Rob?
What was the significance of molecular weight? Is it just
What was that? Sorry.
what was the significance of the molecular weight being what it is?
Just that it's low, so it means that it's got a low boiling point.
Okay,
Yeah, and then that
cool.
has its effects as well. Yeah, the phenylephrine one as well. Fortunately, I had a similar one before the actual day, which was good. But I think I answered in the same way, and I think it's good that you fell back on the, you know, coronary artery supply like equation, the cardiac output equation. I think that one's difficult because there's competing things that kind of contradict each other. So you've got a decrease in your, or you've got an increase in your afterload, but also an increase in your preload. So like, what's the overall effect on your cardiac output? Um, and then yeah, I've got here that yeah, your arteries have a high density of alpha-1 receptors, so functionally you have more of an effect. Um, and then same with the coronary artery supply, you've got competing things. So you've got alpha-1 vasoconstriction, which should increase your resistance and therefore decrease your flow, but you also have increase in your aortic diastolic pressure as well. Um, they did a lot of sort of like prompting along the way as well. So talking about the effects of heart rate and things, which you knew. Um, yeah, the question about the what would happen if you got a a really large dose, whether you'd treat it or not. I've got here that it's got quite a short half-life, like 2 to 3 minutes. So whether you can kind of just wait it out or not. Or if you were to treat it, just give something short acting. And then avoiding a beta blocker. So they did ask specifically, like, would you treat it with a beta blocker? And I was initially like, yes. And then they're like, what about the heart rate? I was like, actually, no. Um, and
Mm.
then it did go on to a little bit of structure activity stuff. So, like, why is it metabolized so quickly? So knowing that it's MAO but not
Oh,
conduct.
yeah.
And then the other question they asked was, does it cross the blood-brain barrier and why? So yeah, I feel like it was a good one. They kind of covered a few different topics and a bit of overlap between physiology and pharmacology. But yeah, I think you did really well.
That was a really good one, Derek. Thanks for that one.
No worries.
Well done. Like, there's a couple of things that when I was listening and I was writing down notes, just going back to how you use your words efficiently. And for people listening, I don't want them to aspire to be like Robbie because I think that's probably unrealistic. That was really high level vibing. Um, like when Derek asked you, what's the effect on O2 demand, coronary O2 demand with the bolus, and you were using your words efficiently, like you said. There's a impact on wall tension as well as all the other things. Like those kind of phrases, without going into too much, like saying Laplace's law is affected, that's how you can answer something at a high level by using those kind of buzzwords. Like I'm talking about wall tension here, I'm talking about the balance between heart rate and supply. The word that I just heard Derek mention a few times is competing interest. That's actually a buzzword that you'll learn for your part two exam because you get a lot of part two Viva scenarios where you get these competing interests. This patient's got a TBI, but it also has a hemorrhage from a trauma. So do you keep the blood pressure high for a TBI or do you keep the blood pressure low because they got a trauma and, based on your trauma principles? And you can use that, especially in the cardiac context, for most cardiac fibers, because you can say there's competing physiological things that are going to happen here, and that's like a really high level answering, but it's like a non-technical skill because the first non-technical skill is categorization, and you categorize everything really well. And even when you were asked a question like, "What's the overall effect on cardiac output?" You didn't just go into the overall effect on cardiac output is this. I wrote down here, you said specifically depends on the state of the patient. You took a step back, and while you were answering so rapidly, I was really impressed by the fact that you were able to take a step back and be like, no, I'm going to give you a global answer, and then I'm going to go boom, 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 boom. Um, and that's really high level vibing to the point where I'm like, you will easily get through this exam if you just stay at this level. Um, but yeah, that's just a couple of extra things that I noted while you were doing that. I was just writing down notes. I just had to just point them out.
No, thanks,
Uh,
Arnie.
In terms of my vibers, they're a bit unfair, and I think you did really well on both of them because they're both opening Viva stems from the 2025 first exam. And the first one is really about bleeding, but more so about von Willebrand factor. And it's not just so much about understanding von Willebrand factor, it's understanding why is it that we do certain tests and how the coagulation cascade is activated. And you went through it really well. You even answered questions that I would have said if you didn't answer them, like it's a minor point, like the receptors that are on the platelet membranes that von Willebrand factor and collagen bind to. The point of this Viva, when I was trying to make them, is, as I say, I try to make Vivas that have some facts, some understanding, and some clinical reasoning. And then I see push you to the point where you're trying to learn something new or come up with something new at the end to see whether you're a four or a five in my head. And the point that was here was understanding that we talk about one Willebrand factor quite a lot. It's not just important in the platelet adhesion part of the platelet adhesion activation aggregation process, but it's also important in the platelet um, aggregation aspect. And then knowing a bit more about von Willebrand factor, I can see where you're then sitting in terms of your knowledge. Like, do you recognize that it's linked to factor eight? Well, if I tell you that it's linked to factor eight, what blood test would it affect? Well, it would affect the intrinsic pathway. Okay, what is the intrinsic pathway? The intrinsic pathway is this, and it's activated by thrombin. You're going back to then basic knowledge with some high level knowledge of things that are a bit more periphery. So if you didn't know all that stuff, I would have been a lot more lenient, but you seem to know it all really well to the point where we were getting to the end when we were talking about the fibrillating pathway. And you can kind of guess that you're doing really well when I'm starting to ask you about different things now. I'm asking you about doses of, my next question was going to be what's the dose of TXA? You obviously passed the Viva when I've got to that stage. Um, there's not much feedback I can give you because you were literally, it was like you were AIing this Viva. I asked you a question. Yeah. The next question you had the answer to. The next question that you had the answer to. And I'm like, okay, I'm going to get through this Viva really quickly. Um, the lignocaine one, I kind of set up. It's a bit better example of a fact that everyone knows, like the dose of lignocaine, 3 milligrams or 4 milligrams, whatever you want to quote. I was happy with the range between 3 to 4.5 milligrams per kilogram without adrenaline, and up to 7 milligrams with adrenaline. But then you take another fact that you might know, like what's the airway topicalization dose. But the two things you never think about is why is the airway topicalization dose higher than the dose with adrenaline? Um, and that's because most of the drug that you're giving with airway topicalization will usually be swallowed by the patient or absorbed by the patient and go down gastric content. And gastric absorption is going to be low. So then okay, I know the fact, but why is this understanding at a higher level comparatively? Can you connect those two dots? Then can you connect the third dot, which is why is that dose lower in a pediatric population? And that's probably due to the fact that they have lower metabolism because their liver is immature comparatively to an adult. So then what other groups from a clinical aspect is that also a risk in? And you mentioned the elderly, the pregnant, and those with severe liver injury would be the other group. So that's like your understanding of that fact. And then we go into reversing the Viva and thinking about if this Viva went down further, we talked about toxicities and other things, but it's like, well, we give this drug IV at a plasma concentration that's really high. You know, if you give, there's a classic SAQ question, which is the ropivacaine overdose. And if you look at the Ketamine Nightmares answer, it figures out that it's given like 25 mics per mil in terms of the plasma concentration. So if you give someone a 1 milligram per kilogram bolus, in the acute phase, as that drug is injected, because we all know we just inject the lignocaine straight away. We don't give it slowly. Although you should give it over like a 10-minute loading dose. We give it really quickly. And that peak plasma concentration can be anywhere between 10 to 20 mics per mil. So it's within that range of understanding, well, we're at the range that you were saying that you would get CNS toxicity occurring, but why is it that we don't see that effect? And you got to it. You said, well, majority would have been protein bound. And if we did really well, the next question, which I'm not saying you didn't do really well, if we had time, I would have asked you what's the difference between plasma half-life time versus terminal half-life time of this drug. And the plasma half-life of lignocaine is 8 to 15 minutes. And so as you inject that drug, well, the half-life is still a reasonable amount of time. Why is it still I'm not getting toxicity? And it's because that drug goes into the liver and the majority of it gets metabolized. So then how are drugs classified when they get metabolized by the liver? They're either classified as flow-limited drugs or capacity-limited drugs. And what does that mean? Well, it means that the extraction ratio is really high and all local anesthetics are usually flow-limited drugs. So that's why as soon as you give that plasma concentration of that drug at a high dose, it's already being reduced by zero point 0.7 of a fraction by the time it goes through the liver once. And you can give it safely, and that's why you can run infusions on patients at 1 to 2 milligrams per kilogram an hour, and why you can give that high loading dose with still reaching plasma levels, you know, measured at half an hour based on what study you read at like less than 5 mics per mil. So then the last thing would have been, well, what if we made this drug into a capacity limited drug? So if it was a capacity limited drug which had a low extraction ratio, could you do the same thing? Could you give it at the same dose IV? Would it have the same levels of its safe therapeutic maximum doses? And hopefully you would then go from that being like, oh, understand that you couldn't do that, and the safe maximum dose would be lower, because if it's capacity limited, you don't have that same buffer. But like I said, I made that Viva with like 20 questions, and it's probably a 10-minute Viva that you got through within like 5 minutes with just a couple of questions that were just extra. But that was really well done. And I think you should be happy that you're doing this well, and you should be confident of the way you're tracking towards the Viva. But at the same time, keep at the pace that you're going at so that you don't lose momentum while matching and trying to balance, making sure you don't get burnt out. Because I think the way that you're going right now, you're doing really well. And I think Derek would probably agree that you're well on the pathway that you will crush this exam.
No, thanks so much, Ani. I really appreciate it. That's really nice.
Um,
All very good vibes. Thank you so much for putting them together, guys.
Thank you so much for being our guest candidate, and thank you, Derek, for taking time off on a Saturday to do this. I really appreciate it, and I hope the people listening got a lot out of this. And like I said, best of luck on sitting the exam. I know that you will do awesome, and thanks everyone for listening on Count to 10.
Thanks, Ani. Thanks, Derek.